Close your eyes for a moment. Picture the modern operating theater, a beacon of white light, the rhythmic beep of monitors, the quiet assurance of the anesthesiologist. You are told to count backward, and a wave of cool oblivion washes over you. You are safe, you are spared. You wake up and the ordeal is over. But for the overwhelming majority of human history, the serenity, the sanctuary, did not exist. We are about to journey into the age of dread, a dark era when the only difference between surgery and torture was the surgeon's intent. This is the story of medicine before the gift of oblivion. A time when the sound of the saw was inevitably drowned out by the patient's screams. Our anchor in this nightmare is a woman whose words still ring with the agony of that time, Frances Burney. The year is 1811, the location, Paris, France. The celebrated English novelist, aged 59, receives the crushing diagnosis, breast cancer. Her French doctors present the only option for survival, a mastectomy. Anesthesia was not yet invented. It would not arrive for another nearly 5 decades. The prospect of being cut open, while fully conscious and utterly sensitive to every nerve-shredding incision, filled Burney with a sickening, profound dread. Yet, like countless desperate souls before her, she was willing to trade unimaginable agony for the preservation of her life. On the day of her operation, she would have been blindfolded, positioned on a makeshift table, and physically restrained by 4 or more strong dressers or medical assistants. Their primary, harrowing job was to hold the patient down while the surgeon performed his gruesome task with blinding speed. For Burney, every second was a descent into hell. She wrote about the experience to her sister, documenting a trauma that defined an entire era of medicine. When the dreadful steel was plunged into the breast, cutting through veins, arteries, flesh, nerves, I needed no injunctions not to restrain my cries, Burney wrote. I began a scream that lasted unremittingly during the whole time of the incision, and I almost marvel that it rings not in my ears still. So excruciating was the agony. The shock of the pain was so intense that Burney lost consciousness twice, but miraculously, she survived the ordeal. She healed and went on to live another 29 years. Frances Burney was one of the incredibly lucky few who survived major surgery in an era without general anesthesia or even a basic understanding of germ theory. As the retired surgeon and medical historian Ira Rutko notes, there's always a debate about what were the most important moments in human history, but certainly pain relief in the mid-19th century was one of the greatest. That was followed 40 years later by the discovery of bacteria and viruses. For centuries before those two scientific landmarks, surgery was an agonizing ordeal, reserved only for the most life-threatening emergencies. The concept of surgery as we know it, precise, contemplative, and curative, was simply unthinkable. The first rule of pre-anesthesia surgery was simple: get it over with. Join us now as we dissect the mechanics, the rituals, and the desperate remedies of surgery when the patient was the last line of defense against both the blade and the terror. The butcher's art. Mechanics of pre-anesthesia. Surgery, the lack of effective, reliable pain relief, fundamentally dictated the limits of surgical ambition. Before 1846, the surgeon's domain was severely restricted. The limits of the scalpel. As Rutko details, doctors could only operate on things they could see and access rapidly. Badly broken bones requiring amputation, rotten teeth, surface tumors, bladder stones, and the external repair of hernias. Internal surgery was forbidden. The concept of operating on something inside the brain, the chest cavity, or the abdomen was utterly off limits. There were 4 critical reasons why these areas were considered the forbidden zones. Ignorance of anatomy and physiology. While some anatomy was known from dissection, the complex functions of internal organs and their response to trauma were poorly understood. Opening the abdomen often led to immediate, fatal sepsis or shock. Lack of hemostasis, stopping bleeding. Techniques for reliably clamping and cauterizing major vessels were crude. Uncontrolled arterial bleeding meant certain, swift death. a race the surgeon could not win without speed. The pain factor. The excruciating agony meant the patient was fighting, thrashing, and screaming. This forced the surgeon into a chaotic speed run, making delicate, internal work impossible. Imagine attempting microsurgery on a person wrestling with 4 attendants. No germ theory. The greatest killer was not the operation itself, but the invisible enemy infection. Every cut, every contact with unsterilized tools and unwashed hands introduced bacteria. Since the chest and abdominal cavities are highly susceptible to sepsis, exploring them was almost a guaranteed death sentence from post-operative peritonitis or pleurisy. B. The cult of speed. Because pain relief was negligible and bleeding control was difficult under duress, time was the pre-anesthesia surgeon's mortal enemy. The longer the patient remained on the table, the greater the suffering, and critically, the greater the likelihood of death from hemorrhage or surgical shock. Surgical success was measured in seconds. This meant that technical proficiency evolved not into precision, but into blistering velocity. Amputations. The surgeon's true test. Amputation was the quintessential procedure of the age. It was a common necessity due to battlefield injuries, compound fractures, and late-stage infections. A surgeon's reputation was built on how quickly they could perform this brutal act. By the 19th century, doctors knew anatomy and they knew how to stop the bleeding, but they couldn't stop the pain, so they would try to perform an amputation of an arm or a leg in 25 seconds, Rutko explains. In less than 30 seconds, that leg was gone. The environment of the operating theater was not one of quiet contemplation. It was a spectacle of urgency and violence. The patient was often placed on a sturdy wooden table, not for comfort, but for stability against the struggle. Assistants, or dressers, were selected for their sheer physical strength. Robert Liston, the fastest knife in the West. The era's undisputed champion of speed was the Scottish surgeon Robert Liston. Operating out of London in the 1840s, Liston was known for his dramatic flair and terrifying efficiency. He would reportedly storm into his theater, brandishing his straight knife, and cry out to his audience of medical students and onlookers, "Time me, gentlemen, time me." Liston could slice open a patient's thigh with one sweeping cut and saw through the bone in approximately 25 seconds. To save precious seconds, it is famously documented that he would hold the bloody scalpel handle between his teeth while he grabbed the saw. Liston's success rate was a staggering 5 out of 6 amputees surviving, an exceptional figure for the time. However, his speed was so extreme that it occasionally led to infamous disaster. In one historically catastrophic operation, performed at his characteristic breakneck pace, he rapidly amputated the patient's leg. In his haste, he accidentally cut off the fingers of one of the chief dressers holding the patient down. A third observer, an elderly gentleman standing too close, died of shock, possibly from witnessing the horror. Both the patient and the dresser died later of hospital gangrene, infection. This infamous operation is sometimes cited as the only surgical procedure in history with a 300% mortality rate. It starkly illustrates the razor-thin margin between life and catastrophic failure. In the age of dread, the surgeon's skill was paramount, but the patient's constitution and tolerance for shock were equally crucial. 2. Desperate remedies. The search for oblivion. For thousands of years, long before the discovery of ether, doctors and healers around the world experimented with any substance, herb, or ritual that might offer even marginal relief from surgical agony. These ancient solutions were often dangerous, unpredictable, and ultimately inadequate. Opium, the timeless analgesic, the most reliable agent available throughout antiquity and the Middle Ages, was the opium poppy. As early as 4000 BC, the Sumerians documented the use of the opium poppy, the source of morphine and codeine. Opium, consumed orally or applied topically, offered powerful analgesia, pain relief, and induced somnolence, drowsiness. However, it did not provide anesthesia, the complete, reversible loss of consciousness and sensation necessary for surgery. The patient was groggy, maybe compliant, and certainly less reactive, but still aware of the crushing trauma to their body. Furthermore, dosing was guesswork, and a heavy dose risked fatal respiratory depression. B. Ancient herbal cocktails around the world. Different cultures blended potent botanicals. The Chinese mixture. Mephizin, the legendary Chinese physician Hua Tu, who lived at the turn of the 3rd century AD, administered an herbal cocktail called mephizin to his surgical patients. The exact recipe is lost, but it likely included cannabis, wine, and possibly wolfsbane, aconite. Wolfsbane contains a powerful and potentially deadly neurotoxin. Hua Tu's patients faced a dual risk: the surgery itself and poisoning from the pain relief. The soporific sponge, nearly a millennium before ether and chloroform were inhaled as modern surgical anesthetics, the Persian physician Ibn Sina, Avicenna, AD 980 to 1037, recorded a similar inhalation technique called the soporific sponge. A bundle of rags was soaked in a potent herbal concoction. Recipes included mandrake, henbane, opium, and wine. Mandrake and henbane contain potent tropane alkaloids, hyoscine, atropine, that are powerful sedatives and deliriants. The sponge was held under the patient's nose, inducing what later Islamic physicians called the Great Rest. While sometimes effective, these compounds were highly toxic, and a dose that achieved true oblivion could easily stop the patient's breathing forever. C. Peruvian. Trepanation and alcohol. In ancient Peru, a type of cranial surgery called trepanation, drilling a hole in the skull to treat head injuries or headaches, was surprisingly common, with evidence of high survival rates. Anthropologists such as John Verano, who studied trepan Peruvian skulls, believe that Incan and earlier cultures may have used chicha, a corn beer, to relax the patient. Alcohol, as a depressant, would reduce anxiety and sensitivity. However, the common misconception that coca leaves, the source of cocaine, provided significant anesthetic relief is refuted by Verano. Coca leaves may have been chewed during the operation. People say it calms you down, but coca is a mild stimulant. It's not an anesthetic by any means. It doesn't put you out. Be the brutal truth of physical sedation. When herbal remedies failed, or when speed was paramount, the ultimate pain relief method was physical trauma. The mallet and the blow. In extreme emergencies, some surgeons resorted to delivering a quick, sharp blow to the head with a mallet to render the patient unconscious. This was, of course, a high-risk gamble that could result in permanent brain damage or death. Strangulation. Another desperate measure was to apply pressure to the patient's carotid arteries in the neck, inducing cerebral ischemia and temporary unconsciousness. This was incredibly risky, often causing irreversible brain damage or a fatal stroke. The fear of the knife. Ultimately, the patient's own fear and shock acted as a kind of grim natural sedation. Many patients, facing the dreadful spectacle of the operating room, would simply faint from the sheer terror, offering the surgeon a brief, unpredictable window to work. All these methods, the botanicals, the alcohol, the physical violence, were stopgaps. They were desperate measures in a world that craved a solution to the unbearable agony of surgical necessity. 3. The rise and fall of mesmerism. Pseudoscience in the operating theater. In the years immediately preceding the discovery of ether, the medical world, desperate for an alternative to pure suffering, briefly embraced a bizarre pseudoscience: hypnotism, then known as mesmerism, of Franz Anton Mesmer, and animal magnetism. The trend originated with Austrian physician Franz Anton Mesmer, 1734 to 1815. Mesmer developed a complex theory claiming that all illness was caused by blockages or imbalances in a universal, invisible life force he called animal magnetism. He initially used magnets to affect this fluid, but later claimed that he, as the operator, could channel this force through his hands, voice, or even his gaze, inducing the trance state. Mesmerism involved putting patients into a deep sleep or trance, often involving dramatic public sessions. While mesmerism as a medical practice was widely discredited in the 18th century, a French commission involving Benjamin Franklin and Antoine Lavoisier concluded the effects were due to imagination rather than a magnetic fluid. It experienced a peculiar and very serious revival in the 1840s as a form of anesthesia. B. The mesmeric surge in England. British practitioners, notably physician John Elliotson, promoted mesmerism vigorously in the pages of The Lancet. Elliotson, a respected surgeon at University College Hospital in London, began performing surgeries on patients placed in a mesmeric trance. These operations often took on the air of a public spectacle. In front of live London audiences, which sometimes included figures like Charles Dickens and Michael Faraday, Elliotson would remove tumors or perform minor procedures on patients who allegedly felt no pain. The critics were harsh. Fast surgeon Robert Liston dismissed mesmerism as a theatrical trick, believing the patients were either charlatans or simply under extreme suggestion, not true anesthesia. The debate became toxic, and Elliotson was eventually forced out of his teaching post, though he continued to practice privately. C. The Calcutta Mesmeric Hospital. The most successful and controversial proponent of mesmeric surgery was James Estale, a Scottish surgeon working in British India. Conditions in the tropics meant that patients often developed massive scrotal tumors, hydrocele and hernias that required removal. In 1846, Estale opened the Calcutta Mesmeric Hospital. He used hypnosis extensively, sedating patients for amputations, cataract surgeries, and most famously, the removal of those enormous scrotal tumors. Estale claimed a remarkable success rate in reducing pain, but his methods were also scrutinized. Even if the patient felt no pain during the procedure, the post-operative infection rate remained deadly, as the germ theory was still unknown. Estale's work highlighted a truth: mesmerism, at its best, could manage the acute pain and shock of the incision itself, but it was unreliable, time-consuming to induce, and entirely dependent on the patient's suggestibility. It could calm the mind, but it could not reliably stop the body from reacting to trauma. D. The mesmerism moment and Liston's conversion. The debate reached its fever pitch just as the real revolution was crossing the Atlantic. In December 1846, Robert Liston received a shipment of ether from America. He decided to try this Yankee dodge on a patient named Frederick Churchill, who required a leg amputation. Liston administered the inhaled vapor, waited a few minutes, and then, with his characteristic speed, performed the amputation. When the patient woke up, he looked around and asked the famous question, "When are you going to begin?" Floored by the undeniable, absolute power of the anesthetic, Liston immediately converted. Standing before his former colleagues and students, many of whom had supported mesmerism, Liston proclaimed, "This Yankee Dodge, gentlemen, beats mesmerism hollow." The age of dread, which had briefly flirted with stage hypnotism, was suddenly and irreversibly over. 4. The two great revolutions, from torture to therapy. The transformation of surgery into a truly healing art required two distinct, world-changing discoveries, separated by 2 decades. Anesthesia solved the problem of pain and shock. Antisepsis solved the problem of death by infection. A. The first revolution. Anesthesia, 1846. The use of ether in 1846, followed quickly by chloroform, pioneered by James Young Simpson, Edinburgh, for obstetrics in 1847, was instantaneous and profound. 1. A new surgical philosophy. The most immediate impact was the removal of the need for speed. Surgeons could slow down. 2. Exploration of the forbidden zones. With pain and patient movement controlled, surgeons began to tentatively explore the chest and the abdomen. 3. The birth of specialization. The newfound time and control allowed medicine to move beyond general butchery and into specialization. 4. The cultural shift. For the patient, The operating room was no longer a place of absolute terror. It was a place of hopeful surrender. B. The continued reign of death. Post-anesthesia mortality. Despite the miracle of anesthesia, the death rate from major surgery remained appallingly high, often hovering around 50% for abdominal procedures and still high for amputations. The patient was no longer screaming, but they were still dying, often days after the operation, from sepsis, gangrene, and erysipelas, skin infection. The problem was not the operation. It was the invisible enemy. Surgeons often worked in blood-soaked coats, proud of the hardened crusts of blood on their garments, a sign of long experience. Tools were reused without sterilization. Dressings were made of unwashed rags. Operating theaters were notoriously filthy. It was a perfect, deadly environment for bacteria. C. The Second Revolution. Germ theory and antisepsis, 1860s. The true liberation of surgery came not from a surgeon, but from a French chemist and microbiologist, Louis Pasteur. 1. Pasteur's groundbreaking work. In the 1860s, Pasteur conclusively proved that microorganisms, germs, in the air, on surfaces, and in liquids were responsible for fermentation, putrefaction, and crucially, disease. His work showed that spontaneous generation was a myth. Disease came from contact with living, microscopic organisms. 2. Lister and the application of theory. Enter Joseph Lister, a brilliant, quiet-spoken Quaker surgeon in Glasgow. Lister read Pasteur's work on fermentation and had a sudden, revolutionary realization. If microscopic organisms cause meat to rot, they must also be causing wounds to rot, i.e., become infected. Lister decided that to prevent this, the wound must be protected from these invisible invaders. He needed a chemical agent to kill the microbes without killing the patient. 3. The carbolic acid solution. Lister learned that carbolic acid, phenol, which was used to treat sewage and keep the stench down, was a potent killer of bacteria. Beginning in 1865, Lister instituted the world's first true antiseptic protocols, asterisk wound care. He soaked dressings in carbolic acid before applying them to compound fractures. Asterisk tool sterilization. He began washing his surgical instruments and hands with a carbolic acid solution. Asterisk the carbolic spray. Most dramatically, he developed a carbolic acid steam spray apparatus to fill the air of the operating theater during the procedure, attempting to sterilize the very atmosphere. 4. The results. The results were immediate and staggering. In Lister's wards, the mortality rate for amputations plummeted from an average of 45% to below 15%. His success was undeniable, yet his methods were initially met with fierce skepticism and ridicule by the established medical community, who saw the spray and the washing as time-wasting, unnecessary fuss. Lister persisted, and by the 1880s, his antiseptic system, the killing of germs before they enter the wound, gave way to the simpler, more effective aseptic system, preventing germs from entering the wound in the first place, via heat sterilization of instruments and gloves. D. The modern legacy. The combination of these two great revolutions, anesthesia in the mid-19th century and antisepsis in the late 19th century, is what transformed surgery from the butcher's art into the science of healing. Anesthesia provided the time for precision. Antisepsis provided the safety for exploration. Today, when a surgeon performs a complex, life-saving operation, whether it is delicate cardiac repair or intricate neurosurgery, they are utilizing the time bought by ether and the safety secured by carbolic acid. They are standing on the shoulders of Burney's sacrifice, Liston's speed, and Lister's quiet, revolutionary brilliance. The screams of the past are now silenced, replaced by the silent miracle of modern medicine. We have truly escaped the age of dread.